Just a reminder that you are listening to the summary version of this discussion.
Let's get straight into it, guys. How high do you reckon the prevalence of hypokalemia is? What percent of patients do you think have hypokalemia? Just take a random guess.
Maybe like 30%.
30?
5 to 10%.
Okay. Roughly it's around 20%. So that's about 1 in 5 patients that have hypokalemia. And in pediatric, it's a bit higher, around 40%. Now, whilst 1 in 5 of patients do have hypokalemia, not all of them do need to get treated. It's only when there's clinically significant signs and symptoms when they do need to get treated. And do you guys know what the cutoff is for potassium levels in terms of when it starts to become hypokalemia?
So isn't the range like 3.5?
Yep, so if they've got less than 3.5, that's when it's going to be hypokalemia.
Yep.
But in terms of the severe hypokalemia,
Severe hypokalemia. No idea.
3.0.
Oh, okay.
So if it's below 3.0, that's when it's going to be severe. So let's start with the causes of hypokalemia. Would any of you like to summarize that?
So we like to classify hypokalemia, whether it is a lack of potassium intake, if it is increased potassium loss, or if it is a redistributive hypokalemia.
Nice.
So when I'm thinking lack of potassium intake, I'm thinking something like an eating disorder and some kind of malnutrition that's led to lack of potassium being consumed. With a potassium loss, there's lots of causes. That can be things relating to overdiuresis with diuretics. It can be relating to vomiting. It can be related to nausea and diarrhea and sweating. Any excessive fluid loss because electrolytes follow that. And then with a redistributive hypokalemia, I'm thinking mainly things relating to either a diabetic ketoacidosis or a metabolic alkalosis.
And Ben, would you like to go through the potassium physiology in terms of action potentials and how that manifests itself in signs and symptoms that we're going to see?
So in terms of symptoms, we're going to have like muscle weakness. And if we go back to our basic physiology, that's due to a decreased membrane potential. And in terms of other symptoms, we need to be looking out for cardiac symptoms like palpitations and arrhythmias. And that's due to the effect that potassium has on the heart.
This can often present as chest pain, discomfort, and you're also looking for signs of respiratory distress due to that muscle weakness. So use of accessory muscles, either putting in too much effort or not putting in effort.
Nice.
So in terms of the hypokalemia workup, so from history to investigations, would either one of you like to take that away?
Well, throughout history, we're going to go through all our differentials and ask questions about that. Like, have they been vomiting recently? Have they had any diarrhea? Are they diabetic? And in terms, when we get to investigations, we're going to be doing an ECG and then doing a VBG to look at the glucose and the electrolytes, that kind of stuff.
Yeah. And then down the track, you'd also want to do an ABG to get a more accurate reading of blood gases as well as the acid-base balance. And in terms of management, what are the main principles that guide treatment?
How severe we think it is. So if it's more severe, we'd be wanting to act more quickly and probably opting for more of a intravenous
And additionally,
potassium
depending
replacement.
on what the comorbid aspects of the hypokalemia are. So if, for example, if you have metabolic acidosis, you would be giving something like bicarbonate with the potassium instead of KCl. Additionally, if you have low phosphate, you could do potassium phosphate. But if every other factor is close to normal, then we would likely consider potassium chloride, as this is the most common administration.
Yeah, nice.